Yeah.
Yeah, we can get it started. Well, first of all, good morning, afternoon, evening, everyone, depending where you are. I'm really excited to be here today with all of you. I'm Beatriz Martinez Lopez. I'm the GloCal PI from the Davis campus. In the veterinary side, so a little bit outlier here, but and we have the great honor to have Monica Maria Diaz today. She works at the University of North Carolina in the School of Medicine and is assistant professor of neurology, co-director of the Global Health for Neurology and Elective Rotation, and vice chair for the American Academy of Neurology and the Global Health section. Um, she has a lot of research interests. You have the CV there, mostly in multiple sclerosis, transverse myelitis, neuromyelitis optica, as well as epidemiology of HIV-associated neurological conditions and other related issues, like, for example, post-COVID neurological complications and things like that. She has an extensive training, and she did a doctor of medicine in the State University of New York, then a Master of Science in South Carolina, the residency in Yale, and then two fellowships, one in neuroinfectious diseases and neuroimmunology in San Diego, and that's why we're talking about California here, and another in global health. And I think this is current in the Universidad Peruana Cayetano Heredia. It's a Fogarty International Center fellowship. So it's really an honor and a pleasure to introduce Monica. She's a GloCal ex-fellow, and she's part of the family. And yeah, we are really eager to see your talk today. And it's a pleasure, Monica, to have you here. Thank you so much for making it. And the floor is
Yeah.
yours.
Thank you so much for the introduction and for inviting me. So I'm going to be kind of going over an overview of how I kind of got to where I am right now, and then maybe talk about some lessons learned and maybe some tips and advice um, that you might want to take or that you might think about taking. So this is just the outline of my talk, and then I'm not going to go through this because Beatrice already mentioned. I did a clinical fellowship. So I'm a neurologist, I should say. I'm a neurologist, and then I did a clinical fellowship in neuroinfectious and neuroimmunology in UCSD, and then kind of stayed on for the GloCal fellowship. And then I was really interested in working in Latin America. My family is from Cuba. I grew up in Miami and I speak Spanish, so it just like made a lot of sense to go to Latin America. And at the time, I think Mexico and Peru were the only countries available in Latin America. I think now there are a lot more. So that's kind of how I ended up in Peru doing this work that I'm going to talk about today. And then after I finished the GloCal fellowship, then I was like looking for faculty positions while I was down in Peru, and then took a position at University of North Carolina at Chapel Hill. So I've been there since January 1st, 2021. Okay, so again, I'm a neurologist, so very interested in the brain. So I'll talk a little bit about global neurology and why it's important. So, global neurology is basically applying these principles of global health to the practice of neurology worldwide. And unfortunately, there's a common misconception that neurology is too specialized for global health, and that the most pressing neurologic issues are better addressed by general practitioners or pediatricians. But we know that that's not true. There are a lot of things that neurologists can do. If you're a clinician, you're familiar with our very detailed neurologic exam that requires a lot of training and residency to really learn how to fine tune. And I think there's a lot that can be done by neurologists internationally. And then there's been a growing interest in global neurology among neurology trainees and many neurologists who do work in the international space. So, the Global Burden of Disease study in 2016 did note that neurologic disorders are the leading cause of disability worldwide and the second leading cause of mortality globally. And 75% of the global burden of neurologic disease is in low to middle income settings. And that includes 80% of all epilepsy cases and 85% of all strokes that are in LMICs. That's why it's really important to characterize what the burden of neurologic disease is and really make sure that these neurologic conditions are appropriately identified, managed, and treated. And this is just a graph from the WHO that shows the median number of adult neurologists per 100,000 population. And then, not surprising, in low income and low middle income settings, there are many countries that have no neurologists available and or maybe one neurologist available to serve the entire country. And then when you go to the high income settings, there are nearly 5 neurologists per 100,000 population. And then this map it's outdated from 2004, but that's like the most recent one that I can find. Just shows like the proportion of neurologists by country. So of course, in the dark blue, you can see that there are more neurologists in the high income settings, also, in parts of Latin America as well. And then in sub-Saharan Africa and parts of Southeast Asia, there are 0 to 0.1 neurologists per 100,000 population. So very few to serve the entire population. So that's why it's really important to increase neurology capacity in many low to middle income settings. And, a lot of my work is kind of trying to address that. So again, I had the great opportunity after I finished my clinical fellowship to do the GloCal fellowship that you can see here, which I know you're all familiar with. And it was actually my first time traveling to Peru. I had never been there before I started the fellowship. So I was, really excited to go. But really, I had like no idea what I was getting myself into because I had like never been there before. So I did have great mentorship from Dr. Patricia Garcia, who was the dean of the School of Public Health at Cayetano Heredia, and Dr. Sergio Lanata, who is a dementia neurologist at UCSF. And then I had my mentor, Dr. Ron Ellis, who's an HIV dementia specialist at UCSD. And you can see there some pictures of the other fellows that were with me during that cohort. And I was part of the 2019 to 2020 cohort, so the COVID onset cohort. So I'll talk a little bit about that. But really, I have to credit my mentors for like making, putting me in touch with the right people and making this project happen. So a lot of my work focuses on dementia and cognitive impairment in people living with HIV. So just to give you some background, there are more than 150,000 reported cases of people living with HIV in Peru. About a quarter of them are over age 40, and about half live in the capital city. The other large proportion lives in the jungle area in Iquitos in the Amazon here that you can see here. And then, prior to this study, there was really no work that had been done in Peru and a lot of Latin America that assessing the prevalence and risk factors of HIV-associated cognitive impairment. And then when we look at cognitive impairment, the criteria have defined it as either mild or HIV-associated dementia. So this is kind of the breakdown of the categories, the severity categories that we use. So again, this was the first study in Peru to ever assess the prevalence and risk factors of HIV-associated neurocognitive disorder, and one of the few in Latin America at the time. So I worked in Via Libre, which is an NGO that serves people living with HIV in central Lima. And it's a really nice facility because they're very well versed in research. They have clinical trials going on. So it was a really good place to start working because they already had research infrastructure available. But I had to kind of start the study from the ground up, right? Like this wasn't a study that was already ongoing. So with the help of this great team that you see here, including nurses, administrative assistants, research assistants, we started the study and we were able to enroll 144 people living with HIV, all over the age of 40, right? Because we know that cognitive impairment tends to happen in older people. And our objectives were to determine the prevalence of neurocognitive impairment and risk factors for neurocognitive impairment in these people living with HIV. We administered a neuropsychological battery, which was about 45 minutes to an hour long. It covered all the 7 cognitive domains and PHQ-9 for depression screening, activities of daily living questionnaire. So we got all of this, which is important to assess cognitive impairment. And then we assessed, demographics, medical characteristics, et cetera. So we've published these findings already a long time ago in 2021. But essentially what we found was that 28% of the entire cohort did have some degree of global cognitive impairment, and the majority of them had deficits in attention working memory, as you can see here. And then when we looked at risk factors, we found that having an HIV-related co-infection, so having had either syphilis or tuberculosis, all of them had been treated in the past. This actually increased the risk of neurocognitive impairment by an odds ratio of almost 3. And we did find that a substantial proportion had depression. So about a quarter of them did screen for depression based on the PHQ-9. So we've published these findings, and then we have other there are other papers that have come out using this work as well. But using this preliminary data that was collected as part of the GloCal fellowship, there were a few things that we realized, right? One is that there are no ideal screening tools that can screen for cognitive impairment in the setting in a person with HIV in the primary care setting, and much less in a Spanish-speaking population. Like, it just doesn't exist, right? So that was one thing that we realized. And then also we wanted to better understand more modifiable risk factors of brain health. So that would include social determinants of health, which we didn't previously assess in the GloCal, study, and identify those that are at higher risk for hand in order to intervene early, right? So that's ideally what we want to identify, is what set of modifiable risk factors predicts HIV-associated neurocognitive disorder. And then again, we wanted to be able to identify hand in this Latin American population using novel tablet-based assessments and these country-specific brain health risk factors. So that kind of led to using this preliminary data that was collected as part of the GloCal Fellowship, and then developing some specific aims for a K-23, which is a career development award through the NIH. So I was lucky enough to have the K-23 funded on the first try. That was in 2022 or 2021, I'm forgetting, but I'm in my 4th year right now of my K-23. It's usually a 5-year award. Using that mentorship and the infrastructure and the funding that the K-23 provides, we've been doing a study since 2022 to enroll more participants and also do these following aims. So now in aim 1, we want to develop a cognitive screening tool on a tablet that can be optimized to detect HIV-associated neurocognitive disorder in Peru. In aim 2, we want to develop a model for hand or HIV-associated neurocognitive disorder risk factors that can predict hand. And then we want to see if this risk factor model can actually improve the diagnostic precision of the cognitive screening tool, right? So the idea is to combine the risk factor model plus the cognitive screening tool, and then see if that can actually improve the precision of being able to identify hand. And then aim 3 is more implementation science focused, where we want to develop a workflow for hand screening within Ministry of Health HIV clinics in Peru. So the idea is to implement this model, this cognitive screening tool and the risk factor model on a tablet, and implement that in the HIV Ministry of Health clinics. So far, our enrollment goal is 450 participants. We actually, this is actually outdated because we had to redo our sample size calculation. So now it's 487. So we've enrolled 487 participants. About a little bit more than 300 people living with HIV and 175 HIV negative controls. All of them are older than age 18. They're all very stable, have undetectable viral loads, and on antiretroviral treatment. And basically, we administer the TAPCAT, which I will show you on the next slides. It's a cognitive screening tool that's been developed by UCSF. And what we did was we adapted it, right? We selected the tests within that battery of tests that best predicted cognitive impairment in this population. And then we validated the tool. So right now we've already adapted it, we've validated the tool, and then what we're doing is doing the risk factor part, which we did simultaneously. So now I'm working with the statistician on developing the risk factor model for this. And then we again worked in two different sites in Lima, Via Libre, where I had previously worked, and now in Hospital Cayetano Heredia. So it's great that we've met enrollment goal already. And then now, looking into the future, we're actually calling participants back to do longitudinal assessments. So anybody that underwent a visit more than a year ago, they're being called back, and we're going to see if this tool functions longitudinally as well. This is what the interface looks like of all the tests. It's about a 1 hour. If you administer the entire battery, it's about 1 hour. And then, again, our intention was to create a brief battery of a brief tool that can be administered in the primary care setting. So no more than 10 minutes. So actually what we did, what we found was that 4 of these tests were actually the ones that best predicted cognitive impairment in HIV. So we've adapted the test and made it slimmer so that it's now just 10 minutes long. And then hopefully that will be implemented in 2 of the HIV clinics. This is what the tool looks like. So this is one of the participants who gave permission to be recorded. So here she has to pick the line that is most parallel to the pick the orange line that's most parallel to the white line. It's a bit challenging, especially for older people. So yeah, so so anyway, that's just one of the tests that we found had good sensitivity and specificity for cognitive impairment. And this is just one of the research assistant, Sophia, who's administering the testing. So future directions, we're at the point where I submitted an R01 in September. It was not funded. And my intention was this R01, NIH R01 was intending to expand the cohort, right? So we wanted to do longitudinal assessments to see if the tool that we've just adapted and validated can be used longitudinally and can actually predict who will develop cognitive decline in the future. But that wasn't funded. So my plan was to resubmit. And then everything has happened at the NIH that I'm sure you're all aware of. So that's kind of been put on hold while I work on some other things. And then, of course, seeking other funding opportunities outside of the NIH for this HIV-related work, I think is also important. So this is just a list of some of the places that I've been looking, and I have another list of funding opportunities at the end of my talk. So we'll see. I think HIV research is a little bit in flux right now with the NIH, but hopefully there are other funding sources that do support this kind of work. And I've just listed some of the ones that I know of, and I'm kind of thinking about submitting a grant to. During the time that I was doing my fellowship, March 15th, 2020, it was COVID. So I had to put enrollment on hold of my HIV study that I just showed you. And then I actually stayed in Lima for like 6 months during during COVID, which was kind of crazy, but it actually worked out really well because I had a lot of time to write and to publish results of my study, but also to establish new collaborations, which previously I felt like I didn't have much time to establish new collaborations and work on new projects. So it was actually great. I got in touch with Dr. Nilton Custodio, who some of you know. He's a really like great dementia neurologist in Peru. And I started to collaborate on different studies with him. I had all this time just kind of sitting around in my apartment and during COVID. So I had the time to be able to publish and analyze data. So working with Dr. Nilton Custodio's group, he has a lot of data available on dementia in different contexts in Lima. So I got the opportunity to kind of analyze some of that data, write up the results, and then had these publications come out of that. And then kind of through the this relationship that we've established with Dr. Custodio and Sergio Lanata, who you saw earlier. We applied for a grant through the Alzheimer's Association that got funded, which was great. And then I'll tell you a little bit about that because that's still ongoing right now. So just to give you a little bit of background, what we want to do with this one particular study is assess prevalence of dementia in a low socioeconomic status district of Lima, of the capital city of Peru, and also determine risk factors. So risk factors in dementia are really important because some of them are modifiable. So the Lancet Commission has actually published on 12 modifiable dementia risk factors. And if all of these that you can see here, this is from the Lancet paper. And if all of these risk factors were modified or were eliminated, you could actually reduce the risk of dementia worldwide by 40%. So that's why, a lot of people have this misconception that there's nothing that you can do about dementia, but there actually is. Like if you actually modify some of these risk factors, like, improving somebody's education, treating their hypertension, giving them hearing aids if they have hearing loss, treating depression, eliminating smoking, all these things can actually reduce the risk of dementia. So that's why I think it's particularly important in the low to middle income settings. Yeah. So again, this is the Alzheimer's Association grant. I do highly recommend it. It is available to PIs outside of the US, which is great. So I do highly recommend that if anybody is doing Alzheimer's work out there, that you look at the Alzheimer's Association International Grant. Usually it's a 3-year grant, and I believe it gives about $350,000 during that 3-year period. So it's not like a lot of money compared to an NIH R01, but it is a good amount, especially in an LMIC. So basically, what we wanted to do was assess the epidemiology or the burden of mild cognitive impairment and dementia in 2 districts of Lima, one socioeconomically vulnerable and one affluent. And then to assess dementia risk factors in both of these districts. So working with Dr. Eder Herrera, who's an epidemiologist and a medical doctor in Peru, he's done a lot of the legwork on the ground for this study. We started working in Puente Piedra, which is on the outskirts of Lima. It's one of the districts with the lowest socioeconomic status in Lima. And then, you could see here, we were doing the field team was doing cognitive assessments in participants' homes and also collecting risk factor data. And here, we were talking with the community stakeholders and community leaders just to make sure that they were on board and supportive of the study before starting the study there. So again, we have finished enrollment in Puente Piedra. We enrolled 1,100 people, both young and older adults. And now we're in, this is actually outdated. So we were going to work in San Isidro, which is the wealthiest district. But we're actually working in Jesus Maria for many reasons. But so that's another affluent area of Lima. So the idea is to compare risk factors in a socioeconomically vulnerable district versus a high income district, and then we'll hopefully be able to develop a risk factor model for dementia in both of these settings and identify risk factors or protective factors for dementia in both of these settings. So just looking at some preliminary data, which we already published, this was based on a subsample of the 1,100 participants that were enrolled. But we actually found that among older adults, 37% had a mild neurocognitive disorder that you can see here. And then among younger adults, 25% had a neurocognitive disorder. This was based only on the cognitive screening tools, not the functional assessment tool. And then so we did find a substantial proportion of younger adults did have some degree of neurocognitive disorder, which was surprising to us. So that's I think something that we really want to look further into. Um, and then we identified some risk factors. So, for example, this is in the older adult group. Having lower education level was a risk factor for mild cognitive impairment in the older adult group. And then in the younger adult group, we found several risk factors. So, lower education level, actually speaking a native language other than Spanish, increased the risk of neurocognitive disorder by 3.3 times, or an odds ratio of 3.3, which was pretty high. And we think, I mean, there might be several reasons for this. Everybody had to be Spanish speaking, but maybe they just feel more comfortable in their native language, and they may not have completely understood the testing, which was done in Spanish. That's a possibility. But also, a lot of these people have migrated from the inner part of the country, right? So from the Andes highlands and the jungle, and they face a lot of stigma, a lot of discrimination sometimes. So even those risk factors can be adverse risk factors for neurocognitive disorder. And then depression also increased the risk of cognitive impairment as well in these younger adults. So we're in the process of publishing this. We've submitted this as a paper. And then right now, the field team is actually working in Jesus Maria in the affluent district that I just mentioned. So continuing to collect data. So that's one study that I think was a good example of, how some of these collaborations just lead to grant funding and then lead to really nice studies. And then, and then I think that's kind of a setup for continuing to submit grants and continuing that funding flow. And then I think, I just want to mention that one of the other interests of mine is the study that I just showed is in Lima, a very like busy, huge capital city. But one of my interests is also working in rural populations, which have generally not been included in many dementia studies. So, and there are a lot of challenges, right? Geographic challenges, environmental, cultural differences, social, linguistic differences. So you have to kind of take all of this into account when you're doing these cognitive tests in other settings. So I've been mentoring she's actually currently a fellow through I forgot the name of the consortium, but it's the University of Washington Fogarty Consortium. So Arantxa Sanchez, she's a medical graduate from Peru. So she's been leading this study in a native community in the Amazon jungle. It's very remote. It's about 5 hours from the nearest city. I think it's a really great study because this work on dementia has really not been done in native communities. There's one study that was done in Bolivia, but it hasn't been done in Peru and in general not been done in much of Latin America. I've been mentoring Arantxa on this project. It's really, really great. I had the opportunity to go with her twice to Balsa Puerto and one, to set up the study, but two, to do the neurology evaluations because we do need a neurologist to do some of these evaluations that we're doing of participants. So in phase one, we adapted and validated the cognitive screening tools, and then in phase two, are looking at the frequency of different neurologic diseases in these native indigenous communities, including dementia, epilepsy, stroke, and Parkinson's disease. So that's why, especially, I think it's important to have a neurologist go into the field and do these assessments because, I think we always do, the field team will do a screening for these conditions, but it's different when you have a neurologist actually like go in and do the evaluations, like the physical examination and the evaluation of the patient to truly see if they have these conditions. So that's what we're working on, and I'm going to be going back with Arantxa and a whole team of neurologists from Lima in last 2 weeks of May. which will be great. I really like going. So this is another example of like, how some of these collaborations can kind of lead to really nice work, especially through the Fogarty Fellowship. And these are just some more pictures of the field team doing some of the assessments, like taking weight, blood pressure. We do a finger stick for glucose monitoring and doing the cognitive assessments that you can see here. So it's been a really nice experience. But again, I think it's also important to highlight that there are challenges to, even though we're doing all this research, I think it's important to translate it to public policy, because otherwise, like, why are we doing this research, right? So there have been a lot of challenges in implementing public policies in aging and dementia in Peru. This is just an outline that shows all the attempts within the Ministry of Health to get some of these public policies implemented. So I will say that all of these laws were passed by the government in Peru, but none of them were actually implemented. And these are all different laws that protect the rights of older people living in Peru, or give them, provide more resources to caregivers or older adults living with dementia. But the truth is that like none of these have ever been implemented. So there are several neurologists now that are working in Peru with the Ministry of Health to design and implement a guideline that will hopefully give recommendations to physicians on how to screen for cognitive impairment, how to manage it in the clinic, and then also improve resources in the country for aging adults. And then this is just some of the work that we've done. So we put together this conference, which was this was actually back in 2022. There was a conference that was put together. We invited Ministry of Health representatives, and then invited several people that are doing dementia work in Peru. And this was just kind of like to promote the work that we're doing within the Ministry of Health, but also show the importance of it, and that we do need public policies to help improve resources among older adults in Peru. And then the GBHI, which you might all be familiar with, is based at UCSF. They also put together a really, really nice workshop in February of this year, which some of you were at. And they've been doing a lot of work with the Ministry of Health to get these public policies implemented. And this was just the National Worldwide Alzheimer's Day, where a lot of the patients with Alzheimer's come, and they, kind of are assessed by neurologists, and they have different activities for them. So, and then last thing that I'll say very quickly is that this is another thing that I wanted to mention, which I have to credit the GloCal Fellowship for, because I think it was through the GloCal Fellowship that I was able to establish these connections with one of my former co-fellows. So I had previously worked, like prior to when I was in residency, I had worked in Uganda as a resident, like just doing a clinical rotation. So I was already familiar with Kampala because I was there I was there twice in residency. So I was kind of like, I was really focused on Latin America at the time. But then I was like interested in doing dementia work in sub-Saharan Africa. So that was, and I had already been to Uganda. So my colleague, my co-fellow from the GloCal Fellowship, Stephen Wandera, who you see here, he he's a gerontologist, so he's very interested in aging of the Ugandan population. A lot of his work has been focused on aging. So we chatted one day. This was like years after we had both finished our fellowships. We reconnected, I think, via like just like by email. I think Stephen reached out to me, and then just saw that I had like done some dementia stuff, and we just reconnected on a Zoom call. And we were like, okay, well, maybe we can apply for an Alzheimer's Association international grant. And we developed this study that I'm going to tell you about, which got funded through the Alzheimer's Association as well. So I had the opportunity to go to Uganda again twice. One, to kind of set up the study, and then two, to like go into the field with the team and kind of supervise a lot of the work that's being done. So here, this was in Makerere, which many of you might be familiar with. So at Makerere University, we were training a lot of the field team to do these cognitive assessments when they go out into the field. So the aims of the study were we want to assess the prevalence of dementia and frailty in two rural communities in eastern Uganda. If any of you are from Uganda, it's in Busia and Namayingo. This is also a door-to-door study, so very similar to the Peru study that I showed you earlier. And we're using two cognitive screening tools, the RUDOS and the IDEA. And we also ask about seizures and a lot of different risk factors like their sleep quality, whether they exercise. We take the nurses, these are two of the nurses on the team who you see here. They take blood pressure, height, weight. We also assess frailty by doing the hand grip strength and timed get up and go test. So a lot of different assessments. And then we also enroll caregivers as well. So for every older adult, the field team also enrolls one caregiver that lives in the home with the participant, with the older adult. So we actually had 602 older adults and 602 caregivers enrolled in total, which is great. And then we've started to look at this data. This was when I was able to go. This was back in October, I think, when I went with the field team, and it was really nice to be out there. And this is Stephen, the my co-PI, and then two of the nurses and the research assistants, and we were out in Busia. So as you can see here, we do frailty assessments, including the hand grip strength, timed get up and go test, which just times how quickly the person can get up from the chair, walk a certain distance, and then walk back and sit down, blood pressures, and cognitive screening tests. So last week, I was at the American Academy of Neurology meeting in San Diego, and here I was with Stephen. So Stephen actually got the top-rated abstract, oral presentation abstract based on this work. So he presented the work that we did at the American Academy of Neurology, and I won't go over all the results in detail, but he kind of talked about all the caregiver results, how caregiver burden was generally high in the population. So about 40% of all caregivers had some degree of caregiver burden, and depression and anxiety in the caregiver were a risk factor for caregiver burden. And then he presented some other findings as well. So I'm just going to wrap up very quickly. So one of the other things that I've done is also develop neurology education in low to middle income settings. That's another interest of mine. So working together with Cayetano Heredia, we put together this rotation for neurology residents. And the idea is that it is a bi-directional rotation, meaning like UNC, we do accept neurology residents from Cayetano Heredia and from the Instituto Nacional de Ciencias Neurológicas, which is like one of the big institutes, neurology institutes in Peru. And then vice versa, we've had two residents from UNC go to Cayetano to rotate. So I won't go into all the details, but basically the UNC resident has the ability to rotate in a lot of these different parts of the hospital, like we're rotating in stroke, neuroinfectious diseases, et cetera. And it's a 4-week rotation. Yeah, and then it's structured very similarly to a rotation in the US, where they have to attend morning rounds. They go to the conferences with the residents, the local residents. And then they have to present at grand rounds about their experience once they finish the rotation. So this was our first UNC resident, James Andrews, who went in, I think, 2023. I was there with him. So yeah, he had a really great experience. He spent 4 weeks on the wards there, kind of learning about, how neurology is practiced in a low to middle income setting, which is very different from all the, from our resources that we have available in the US. And then we had a second neurology resident, Kelby Brown, who did a rotation both in the Instituto and also in Cayetano. Had a very, very nice time. I think he learned a lot as well. But I think one of the important things that I'll mention is that we currently actually have our first resident from Peru rotating in UNC right now. So he just started on Monday in the neuro ICU, and he's very interested in going into either neuro ICU or neuroimmunology. So I think it's great because it's really giving him exposure to some of these subspecialties that are generally not available in Peru. So I think it's a really nice like bidirectional exchange that allows both parties to kind of learn from each other. So I hope Christopher has a good rotation with us at UNC. So yeah, so I was just going to quickly just mention some funding opportunities. So as you know, the NIH unfortunately has changed many of their priorities recently. So I think the truth is that many people just don't know what direction this is going to go in. So I think it's important to diversify funding portfolios at this point, and that's what I've been personally doing, and I'd love to hear what others are doing. Um, as well. But this is just some kind of advice that I've received and some things that I've been doing recently. So I think one good place to look is in your particular specialty or subspecialty. So every specialty has a foundation, right? So I work in multiple sclerosis and HIV and Alzheimer's. So I look at Multiple Sclerosis Society, Alzheimer's Association. They have funding opportunities that are usually available to international investigators and US investigators. So I think that's always the first place to look is within these foundation grants. And then that are specialty based. And then, of course, I mean, there are numerous other ones like UK based. Some of these do allow international investigators to apply. Like Wellcome Trust, I know there are some funding opportunities that do allow international investigators outside the UK, but some of them do require a UK-based PI. And then these are some of the other ones that I know of, like Bill and Melinda Gates, Chan Zuckerberg Initiative, GACD. And then I never thought I was going to be looking at industry within the US, but that is somewhere that I'm looking currently is funding some of the work more in the multiple sclerosis space that I'm interested in. A lot of these pharmaceutical companies do have philanthropic arms that are interested in global health work. It's kind of important to talk to your local representative for that pharmaceutical company and then see if they can put you in touch with the person for that philanthropic arm. So I've been doing that recently to kind of see if I could get some of these research ideas that I have for some of the MS work internationally that I'm also working on funded. So I think that's also something else to look into is keep those opportunities in mind outside of the federal government grants. So just some lessons learned. I think it's always important to try to find opportunities to collaborate. I always say, don't be afraid to reach out to people and just email them if you really admire their work. I will say, most people are very willing to chat with you, or, even if it's not going to lead to anything, at least having a chat is important. And then and that's how I was able to establish a lot of these collaborations that I, mentioned to you was just emailing people and then having a Zoom call. Another thing that I know is important is not knowing when to say no to opportunities that do pop up that may not be in line with your career goals. I think at least me, I have difficulty with that sometimes because it's very easy to just say yes, but I think it's also important to know when to say no if it's not something that's a priority or within your career goals. And then, to get publications, there are some investigators that have previously collected data who may just need that data to be analyzed and written up. So that's a very, easy way to get a publication if you need. But I think it's also important to kind of allocate uninterrupted time to be able to do those analyses and write. And of course, time management is important, which is very difficult in academics. But I think it's also a priority to save time for personal time as well, and being with family. Yeah, so I mean, this is very similar to what I just talked about in terms of grant funding, foundation grants by specialty, those that are interested in global health. I've listed here like Doris Duke, Bill and Melinda Gates, Grand Challenges. Another place, especially for US based investigators, but also international, looking at within your own institutions for pilot funding, I think is also good because some of these pilot funds can go a long way internationally as well. I mentioned NIH funding, which is in flux right now. And then when I was looking for a faculty position, I did negotiate having allocated time to be abroad, which I think is very important. as you're, if you're transitioning from like fellowship to faculty position, um, it's important to have like dedicated time to do research. So yeah, like I was able to obtain that initially by negotiating. And that was like, I didn't have any grant funding at the time. I was like in the process of applying for a K. So yeah, negotiate. That's important. And then I think the last thing that I'll say is like, think about what your niche is, and think about like how you can become the go-to person for XYZ, right? Like whether that's you're like the expert in, I don't know, some, particular surgical technique that can be applied in sub-Saharan Africa, or, just think about like what your niche could be, because then when you develop a niche, then you're approached more often to give talks, to be like that expert that gets invited to be a co-investigator on a grant. So I think that's really important to kind of like take time to reflect and think like, well, what is your particular niche and what can you contribute to scientific research? So that's all I have. These are my mentors, collaborators. This list has grown. This is a very outdated list, but this list has grown significantly in the past couple of years. So yeah, I'm happy to take any questions. And thanks again for inviting me.
Thank you so much, Monica. Okay, any questions? Just feel free to unmute yourself or just use the chat. I have questions, actually. I have a bunch of questions, but one of the ones that I felt like very, very exciting, very interesting, like it's huge amount of work, right? But me being epidemiologist from the animal health side, I was wondering about comorbidities. For example, you have like, parasitic infections or other types of zoonotic agents. I mean, there is a huge burden of, brain parasites that could
Yeah.
affect this. I don't know if you guys are looking into that somehow.
Yeah, that's a good question. So in the HIV study, we are looking at co-infections. So I didn't mention this, but we are doing ELISAs, like of serologic testing. So part of the study is everybody has a blood draw, and then we do serologic testing, including toxo, CMV, what else? Hepatitis B and C, and I think herpes simplex virus. So we're not looking at like, for example, I mean, there wasn't enough funding to do like CAT scans and look for neurocysticercosis or something like that. But there is a high burden of neurocysticercosis if the person is from certain regions of Peru. So that, maybe that's something that we could look into in the future, or even do like ELISA testing, or like Western blot of these participants, looking at like neurocysticercosis or other pathogens. But right now we're not looking at like other pathogens other than the ones that I just mentioned. But yeah. Um,
Okay, there is a question.
I had a I had a
Go
question
ahead.
for you actually about like you mentioned like negotiating like time within your like faculty position for that time abroad. I'm in surgery and we also are a specialty that probably has less people in global health. Um, did you were you negotiating once you already had funding sources, or was it more in the process of also applying for, or kind of how did that go, and any advice you have?
yeah, it's a struggle. No, so when I was looking for a position. I mean, all I had was just the GloCal fellowship. And then I was like, in the process of starting to put together a K, but I didn't have any secured funding at the time, which is why I think negotiating, and I'll be honest, like I talked to one, thing that was in my favor was that I wasn't like restricted to a particular geographic area of the US, which is why, I was in California, and of course I wanted to stay in California, but then I ended up in North Carolina because North Carolina was like really the one that was more willing to support my research and give me the time abroad to be abroad even without grant funding. So yeah, so they were willing to like put some departmental funds to secure that time, that like give me some salary support to be able to be abroad. So so that's why I think it's really important to negotiate. Um, so that's what I did. And I will say, like, I mean, I talked to like many different chairs of different departments, and some of them like laughed at me and they were like, of course, but we don't have funding for that. Like, we're not gonna just give you money. And then and then I did find a few of them that actually were like very interested in developing their global health program within their Department of Neurology and were willing to invest some of their departmental funds to be able to like, protect some of my salary support to be able to be abroad. So it just depends. Like you have to find the places that have that are willing to like prioritize global health, I think. So
Thanks.
Hi, Monica. I have a question a little bit about delegation and you do so many projects. Any one of them would be amazing, but you do like six. And how have you collaborated and how have you transitioned or feel like you're hands-on versus helping support your teammates for success? How do you balance that ownership over a project versus the team-based approach that I think you use?
right. Yeah. So that's a great question. And I think a lot of it depends on like what phase of your career you're in, right? Because like when I was doing my GloCal fellowship, I was the one doing all the cognitive assessments and I was the one that was like doing everything in the clinic and enrolling participants and doing all the evaluations. And then it's kind of like, you get more senior, I guess. You can kind of delegate that work and employ research coordinators that can do that work. So through funding, right? Because you need to have funding to be able to pay people. Through funding, I've been able to like employ like a significant amount of not significant, but like a certain amount of research coordinators to do the work in Peru. In Uganda, the grant with Stephen supports all of the field team. So a lot of the hands-on work is done by other people, and then a lot of what I do is like I'll usually employ like a project manager. So for example, like Eder Herrera, who I think you met, Greg, in the GBHI workshop. So he's kind of like the project manager, right? Where he like goes into the field and supervises everything, and like usually having like a good project manager who you trust and who you confide in, and is going to like do a good work of supervising, is really what's needed, I think, especially for a lot of the field work. Yeah, and then in terms of ownership, like I think, I always like, I always discuss like authorship up front, right? And how we're gonna like if we're gonna put together a paper, who's gonna be senior author, who's gonna be first author, like we have to have all of this like, kind of not in writing, but like defined before starting to write a paper. So I think it just depends. Like sometimes, like for example, with Stephen, there's like one paper that I wrote on risk factors of dementia, and I analyzed all the data. So for that one, we agreed I'm going to be first author, and he's going to be senior author, and then he's doing the caregiver part. So he's going to be first author, and then I'm going to be senior author. So we kind of like switch like that, but we've had this discussion beforehand. So yeah, so I think I hope that answers your question, but yeah, so I think it's just important to like talk about those things beforehand. Before you start writing or anything like that.
Yeah, thank you. Thank you. It's interesting to see how to navigate those situations, but I think you're doing it very well and beautifully.
Oh, thank you. It looks like there's a comment in the chat. Oh, thanks for all the nice words. So in Mozambique, we have high rates of epilepsy and people living with HIV associated with toxoplasmosis and neurosis. Yeah. So yes, that is. That's actually a really good point. Like for example, in that study that I showed you that Arangsa is leading in a native community, we are assessing for epilepsy, but we don't have enough funding through the Fogarty Fellowship to do serologic testing or neurosis or toxoplasmosis. But I think Arangsa, I know, is applying to the Alzheimer's Association International grant, so that hopefully will be able to give funding to get some specimens, right, to get some blood samples of those people with epilepsy. So I think it's a good point that we have to look at in the future.
Okay. Any last comment? Have 1 minute left, but I think again it's been a pleasure, Monica. Thank you so much for the incredible talk. I think it was very wonderful for many aspects, right? Not just the scientific content, but all the tips and all the recommendations. I think they're great for like, early career investigators. I definitely it's something that I think everybody has appreciated. Yeah, kudos. Thank you so much, everyone, for coming
Thank
today.
you.
It was an
Yeah.
honor, and yeah, really thank you for attending all. And please feel free to reach out, Monica, if you have further questions or comments. Okay. Monica, thanks a
Okay,
lot
great.
again for the time. It was really interesting. Definitely.
Yeah, thank you so much for inviting me. Um, have a good day.
Thanks, Monica. Always great
All
to hear
right.
from you. Thanks.
Yeah. Thanks, Kimberly. Bye.
See you.
Bye.
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 Bye.